Good morning, everyone, and welcome for our monthly live broadcast for the peripheral intervention cases from Cardiac Cath Lab of Mount Sinai Hospital, New York City. I welcome you today for another very interesting live case. I'm your moderator, Vishal Kapoor, for the day. Before I take you over to the lab, just wanted to let you know, as always, our cases are available on the website ccclivecases.org. You can go to the archive sections for the previous live cases which have been done in the past months, specifically even from March 28th. And the live case from today will be available by the end of the day on the website as well. You can email us at info@ccclivecases.org for any questions, concerns, comments, or recommendations you might have. Before I again go over to the lab, just wanted to let you know this second year in succession, Link Mount Sinai has been collaborating with the CCVVC Symposium and having our endovascular symposium here in New York City on June 12th and June 13th, and it will be preceded by one day of endovascular fellows course will be June 11th on the Monday. So please go on our website cccsymposium.org to register for the fellows course and link mountsinai.org for our Link Mount Sinai session. We hope to provide you with excellent cases and experts from all around the world to give you a very in-depth view of how endovascular updates and procedures have been doing all around. So without further ado, I'll hand over to our star operator and the boss of the lab, PK. Good morning, PK.
Hey, good morning, Vishal. How are you? Good morning. I want to welcome all of you to our lab. As you know, this is our monthly webcast, and I'd like to reiterate all the things that Dr. Kapoor was saying. You know, this is our second year collaborating with our friends in Germany in the Link group with Dr. Scheinert and Dr. Schmidt to actually form a collaborative conference called Link Mount Sinai. Link Mount Sinai, this year we made a lot of different changes, and one is we've incorporated a technical forum in which there will be, you know, 4 to 5 one-hour cases that will be completely done like the case that we're going to do here today with a smaller room, approximately about 100 to 110 people, and moderators as well as experts on the panel. So, and there'll be an ample availability for you to participate with this case, because you can actually ask questions to the moderator, which will then be in turn sent to the operator, and they will answer your questions as they're doing the case. The second part of the symposium that's very exciting is that, you know, we've further increased our collaboration with our good friends down in interventional radiology as well as in vascular surgery. So there's a same thing, the technical forum will occur in vascular surgery with Dr. McKinsey and Dr. Torcello and all their colleagues doing very, very complex cases again. You know, fenestrated aortic grafts, aortic dissections, things that take normally 2 to 3 hours will be able to see live at Link Mount Sinai. Again, as Dr. Kapoor reiterated, we are going to have the usual didactic section with shorter cases, about 2 20-minute cases or 3 20-minute cases per session. So all in total, you're really looking at a symposium in which you're probably going to end up in 2 days seeing 30 to 40 cases done live in front of you. Some tape recorded from radiology because of the nature of the cases, but other than that, majority of them will be live. So which will be phenomenal. Dr. Kapoor, myself, and all the directors really hope that all of you make it out to New York. It's a beautiful time of year in June. And for the fellows out there, the endovascular fellows course, which Dr. Kapoor is a co-director of, will be there as well. You know, and it's again completely different, and you can learn more about that in our website. The second thing is, in the fellows course, we have a fellows case competition. So Dr. Kapoor has generously donated a couple of laptops. He doesn't know it yet, but he's actually donated a few laptops and all these things. So our prize winners will receive really wonderful prizes, all kidding aside, which I think are really much more than you would ever get in any other conference. I think this is not so much to tempt you, but really to entice you to come and really submit your cases to be judged and to participate. You'll also get the opportunity to present these cases in front of your colleagues at the end of the fellows course, and I think you'll have a panel there. I know you'll have a panel there to also talk about it. So I really want you to take this seriously and join us. Anyway, long-winded presentation and introduction, but I'd like to introduce our team. Dr. Sandeep Singla is to the right. He's our endovascular fellow. Dr. Ray Lascano, our interventional NP. Dr. Karthik Guja, unfortunately, stuck in real serious traffic in the LIE, and a shout out to him. He is on his way and may join us in the middle. Elizabeth Holton in the back. Pablo Enriquez, kind enough to join us today. And Damian Cabrera, who's our who's our other technician who's helping us set up this case. So we have a really interesting case, and without further ado, Sandeep will present it.
Sure. Good morning, everybody. So we have an 83-year-old lady. She has a pretty independent living, and her past medical history is significant for hypertension, dyslipidemia, and hypertension. She has a known history of peripheral arterial disease, and she underwent a right SFA angioplasty in 2016, which she says is doing good. But she presented to us in clinic about 6 months ago with complaints of worsening claudication in the left leg. We knew about her disease back then, but it was about 50%. We gave her a trial of cilostazol. She did okay for about a year, but her claudication worsened over the last 3 to 6 months. And then she, right now, her claudication distance is about a block and a half. Next slide. So coming to her labs, pretty unremarkable other than a creatinine of 1.3. And her ABIs, which we did about 2 months ago, on the right, she has 0.94, and on the left, she has a 0.74. We're going to show you some angios we took live today.
Okay, so the other non-invasive workup is she has a outside ultrasound, which also showed significant velocities. So anyway, just angiogram, as you can see, the right common femoral artery visual, not calcified, but tortuous, a little tortuous, nothing crazy. And then aortogram again shows some calcific bifurcation, a little bit of a acute angle in the left iliac that you have to be careful when you're going up and over. And then when you look at the runoff here, I think you'll see immediately startling is the calcium. You'll see the level of calcium that she has at the level of the superficial femoral artery in the ductal canal, coming down to the popliteal, relatively healthy visual, and then this is again a poor version of seeing this, but you can see generally looks like, at least without DSA pictures, single vessel runoff to the foot via the perineal. Here's an example of the level of the tram track calcium that you've seen, dry cine, and really kind of interesting that it's focused to the level of your ductal canal, which is not surprising actually. I should say it's usually standard. So here's your, again, picture showing a really severely stenotic, punched out SFA stenosis, which seems to be relatively focal. And then you can see here at the level of the perineal, at the level of the popliteal, a little bit slower flow, but clearly the trifurcation seems to be preserved. Again, anterior tibial artery has some moderate stenosis proximally. Perineal artery seems to be open. Posterior tibial artery seems to be occluded. In the mid-distal lower part of the limb, I think you can clearly see here very nicely that the anterior tibial artery is going to peter out as it comes. The perineal is the dominant vessel, and there's your severe stenosis in the anterior tibial. Anterior tibial reforms distally, and then you can see here that you can actually see it in the foot light up as a negative shadow, but it's clearly in the foot. And then on the foot shot, which I think is, again, very important. And I think, you and I, Vishal, talk to the fellows all the time about really doing completion angiograms. And you can see here, you can clearly see that she has the dorsalis pedis into the foot and to the and the perineal as well. So I guess the real talking points to you are you have a claudicant, failed maximum medical therapy, severely calcified femoral popliteal disease. And the answer is, obviously, I don't think that anybody would, including our surgical colleagues, would consider surgery for this patient. What is the best endo way, and what would your approach be to doing this case?
Yeah, it's a very interesting case. If you really, the degree of calcification is very impressive. I'm sure if Fabrizio Fenoli was here, he would say probably it's like severe calcification. And in this case, even though, like you said, below the knee vessels are preserved, this probably might need a good degree of plaque or calcium modification in order to attain good results, because we know that if we don't modify the calcification, we are bound by the patency being lower and the revascularization being higher. So in my approach in this would be probably aggressive atherectomy. That, again, could be our next level of discussion of what kind of atherectomy are we looking at. And what techniques and other stuff. And the eventual result will be after ballooning, how does it look? Do we need any stenting? Is there dissection? Do we need just DCB? Do we need PTA or different kinds of technique? But personally, I think atherectomy will be my first go-to step, followed by balloon angioplasty, and then decide our next algorithm or mode.
So I think those are great points. And I think a lot of us, when we make our decisions, we look at it and we say, well, I look at it this way, and I think Vishal would agree, is when I look at this lesion, what are the challenges? What are my challenges here? What do I want to avoid? You dummy it down. So one, I got a lesion. Well, my first challenge is I got to open this lesion. So what are the challenges about opening that lesion? Well, I got calcium. Okay. So in that calcium, the calcium itself is going to provide difficulty for what? One, it's going to provide the difficulty that I may not be able to get through the lesion if it's calcified. But in this case, it's not an occlusion. So I'll probably get through. Second is I may or may not be able to expand the lesion, right? Because of this. So that's definitely a possibility. Third is I may embolize some particles downstream, right? So that's my third conclusion, or my third obstacle. Fourth is if I do all those things safely, I expand the lesion, I embolize, I don't embolize, then I may dissect the lesion. So I may have to stent, or I may perforate the lesion while I'm doing one of the, trying to expand the lesion. So, so you need to have a plan in order to be able to tackle this very, very cleanly. And the only way you're going to come up with that plan is by looking at that angiogram, right? So let's try to learn from our angiogram, okay? And I think this is something, in our Endomasters course that we run with Abbott, I've been discussing this a lot. I've been meeting with a lot of resistance from a lot of really, really intelligent people, much smarter than me. And I think this is going to be an interesting case to kind of showcase what I think, which may be wrong. So let's take a couple of things and we'll open it up to discussion. So one is, I'm worried about embolization. So anything can embolize, everything can embolize, and we know it could come from a sheath, it could come from a clot, it could come from anything. So let's protect. So I know Vishal and I have written a paper in JACC Interventions, and I know we talk about it, which is a suggested algorithm towards using a filter, and this fits that algorithm. Single vessel runoff, severely stenotic anterior tibial. Let's protect. You use an embo shield, put it down off-label, it's protected. Okay, so you're done there. Second, look at the calcium. I want all of you to get into the habit of analyzing the angiogram, and I think it's very important. So if I was to look at this angiogram, I would say, well, where's the beef, right? So where's the calcium? So you have calcium, if I'm looking at your screen, if you're sitting in front of your computer looking at your screen, to the right of the wire, you have some calcium, or the beef. And then if you look below that midpoint where it seems concentric, you have to the left of your wire, okay? So by definition, this is eccentric. So if this is eccentric, so the point is now, okay, so you have eccentric calcium with one area, focal area of concentric calcium. That's wonderful. You've defined your calcium. So by any definition, whether you use the one in CCI, I forgot the name of the classification, but Dr. Roka Singh authored that one. Right. It's severe. Or if you look at the definitive LE definition of calcium, or definitive calcium definition of calcium, it's severe. So by any definition, this is severe calcium. So now you've done that. So you've defined it's partially eccentric, partially concentric, and severe by any definition. But the most important thing is, where's the beef, right? I hate to sound like that. Ray's going to laugh. So is it in the vessel or outside the vessel? And this is my argument towards making a decision on what type of atherectomy you need to use. So you take a luminogram, okay? So angiogram is a luminogram. So when you look at the lumen, you say, well, is there any calcium that I see obstructing my lumen? And can I see any exophytic outgrowths of calcium within my lumen? So let's stop this. So if you look at the lumen here, and you look at the eccentric proximal calcium, there seems to me, at least in my eyes, a compression of the lumen from the exterior, interior, on the eccentric calcium up top of the proximal end of your screen. In the mid, where it's concentric, it again doesn't seem to be obstructing intraluminal flow that I'm able to see. And in the distal, I actually have a pretty good lumen, right? At least by angiogram. So you say, well, Prakash, it's a two-dimensional representation of a three-dimensional image. So let's go to another view. So here's another view, and we're finding the beef. So again, here in the mid, you may see, well, there's a little bit of possible ingrowth in the mid, right? I wish I had a pointer. Can somebody have a pointer or something I can point? Yeah, I can use that. Yep. So can you zoom on me here? I'm going to walk around to the other side. Or actually, I'm going to reach over. In this area, okay, you can possibly see, and play it right.
Yeah, now we can see it.
You can possibly see that there is some calcium. Play it, right? So we're going to play it now. Okay, now watch. Watch as the dye comes through right here.
Right.
Okay? So that lucency, which is what I called about that it's concentric, maybe possibly within the lumen, okay? So that may be your only area of, can you hold on to this because I may need it? Just like that, right there. So possibly that's the area of exophytic calcium, right? So the issue here is, what do? So I think you have to use what available technology you have before you open your equipment. We haven't opened our equipment. So as of now, I'm thinking to myself, my choices are atherectomy, either directional or rotational, or I'm thinking to myself, or if it's calcium that's not within the vessel, am I going to have to do something to expand this to break that external calcium? So possibly a shockwave or a heavy balloon angioplasty, and then maybe scaffolding plus minus DCB, which we'll get to. So then we did the next logical thing, which is let's put an IVUS catheter within the vessel. Pablo? So so Pablo Enriquez, our tech, is going to play the IVUS, and this I think is going to help you a lot. So you can see if you do an IVUS, this is starting distally to proximally. You can see very, very clearly that there's right now very, very minimal plaque within the vessel.
Right, exactly.
And this is what we talk about. And see, there's a compression there. There's Dr. Guja. There's a compression there and a compression there. And I'm going to ask him the point where he marked, which is going to be the most severe spot. So you can see there is some calcified plaque. But Vishal, it looks like there's compression within the vessel. I don't know if you agree. I'll play it a couple of times, and since Dr. Guja is here, we'll get his opinion as well. Whether there's compressive calcium, or do you really believe that it's within the vessel? That's my question to you. So, do you have medial calcification here? That's an outgrowth, or do you have calcium that's actually pushing? Because even in that area, you can see there's a drop off there.
Correct.
So I don't know whether that's within the vessel, and is IVUS a good tool for us to judge since you have that calcium dropout? So I'm going to open this up. Let's ask Sandeep. Sandeep, what do you think?
To me, I think there is a calcium which is adventitial, and this is a process which probably happened. He had a atherosclerotic plaque which calcified, and there is some positive remodeling. The lumen kind of enlarges, so it left some lumen off, but there is definitely calcium in the vessel wall, and we are able to see the lumen because of positive remodeling.
Okay, so the question is, so when you say in the vessel wall, do you feel it's outside compressive, or do you think it's actually medial calcification, which is
not medial,
which is exophytic, which is growing into the lumen and causing obstruction? That's my question.
Yeah, it's not
my question specifically, Vishal, is it obstruction caused by compression, or is it obstruction caused by actual calcium growing in? Because I can tell you, James McKinsey, who was our director of aortic surgery for the system, actually told us that was telling me that when he does common femoral endarterectomies, he sees this type of calcium, but the calcium is actually within the vessel, and thereby he believes that directional atherectomy is the right thing to do. In this situation, I'm curious to what you think. Do you think, are we able to judge by current technologies, including IVUS, where the location of this calcium is? Vishal?
I guess it's a very good point. I mean, in this case, specifically the calcification. So the whole idea is, if the patient has symptoms, are these symptoms coming from these focal points you're actually showing on the IVUS? Or is it because of the degree of, you're right, we get thrown off by just seeing angiographically the degree of calcification. But the question, like you really said, arises, is that calcification, is that really causing intraluminal compromise to decrease the blood flow and thereby causing the symptoms? So I guess getting this IVUS, in this case, it's probably a combination of both. We see so much adventitial calcification, but there's also some luminal compromise.
There is, yeah.
So my argument would be, if I, instead of trying to looking at angiographically very well, if I do those 2 or 3 spots which you show on the IVUS, would I get the same clinical benefit as compared to doing the whole vessel just because it looks bad?
Well, I agree with that point, but my question to you is more towards the therapy that you would do. Because to me, I think if you have, and Karthik is here, we'll ask him in a second. He's looking at the IVUS just to get an idea. So a couple of things that I want to ask you is, do you think it changes your therapy if you have a popcorn or a cauliflower lesion that's growing into the vessel versus something in the outside that's compressing?
Yeah.
Because I think that, that's my question. Because if your IVUS says to you that it's inside the vessel, or you feel it's inside the vessel, is that going to change your therapy versus if it's compressive?
No, definitely. I mean, if the calcification is intraluminal, I would probably go directional or orbital atherectomy. But if it's in the media or the adventitia, we would be just scraping in the lumen with no benefit. And then, like you said, technology like Shockwave or just using a stiff balloon to crack open the calcium to increase the luminal gain would be the next strategy. And then in those cases, these regular day-to-day atherectomy devices might not work at all.
So Karthik is here, and he's incredibly good at IVUS, as you know. So I want to just show him the film because I know
Hi
he's.
Vishal,
Morning,
I'm
Karthik.
sorry. There was
No, you don't have to.
horrible traffic and really bad weather.
No, you don't have to worry about that.
And
But
then-
I mean, but Karthik, so this is a lady who's symptomatic, who's a claudican, who's got very severe calcification. Okay, so with that, she has elevated velocities in the mid, and then I just want to show you run off a single vessel. We put a filter, and what I want to show you is when you see this, you have this type of calcium. So our question to you is, where's the beef? Where's the calcium?
Angiographically, I think this is more adventitial calcium. I
Right.
think this is more extrinsic compression than actually intrinsic. So based on the IVUS, I think there is one.
Comment on the IVUS.
Yeah, there's
So I'm
one
going distal
spot.
to
There's
proximal.
one spot I think in the mid where there is a little bit of
Speckle of calcium.
speckle of calcium coming
Right.
into the vessel, but mostly it looks more like eccentric calcium causing compression of the vessel.
Where is that spot? Tell me where you think you see it. We'll play it a few times because, guys, I think for the audience, when you do watch this, see,
So
it's there.
not here, not here, not here.
because it seems to be pushed in.
Right, not here. One spot where it's
Watch it come.
there's only one single spot. I felt on the IVUS. But mostly it looks more eccentric calcium. I don't think if you're talking about atherectomy here, I don't think it's going to help.
Yeah,
Right here,
exactly.
right here, just a little bit before this. It's very little bit calcium.
It's a very speckled calcium.
It's
which is
speckled
hard to
calcium. I don't think this is I personally feel this is not an atherectomy case. It's more like a shockwave case. You can break it and then I think put a Supera to give more support.
Yep, come
That's
down.
what it looks like.
See, to me, it's hard to tell, and that's where the technology comes in. I mean, IVUS is phenomenal, but I think the IVUS is very good at looking at the lumen.
Yeah.
See, that's to me right here. If you look at it, it seems like the vessel wall
Right
is
here.
Right there.
right there.
Right there.
There it is.
But my question is, how do you know that that's not the adventitia being pushed
Yeah,
in
I mean
by
that's
the
what I'm
calcium?
saying. Just for this spot, I don't think atherectomy is necessary.
Right.
Even this spot
Save
can
that,
be just
guys.
ballooned
Go
up.
in and save that, Pablo.
Right here.
Yeah,
Right,
save
only
that
in
right
this
there.
spot.
Issue is the only reason.
Right there.
The only
Save both.
reason it's intrinsic is because you have a dropout of the wave just below the
That's right.
calcification. So that would suggest that the calcium is intraluminal and there's no echogenic beam going across it, going into the adventitia. I mean, that would be my argument.
Well,
for it.
and angiographically, you also saw what Karthik missed, we were showing where we think it is, right? And I remember because I froze the IVUS, and I want to show you where
My understanding
I
is
froze
this
the
one
IVUS.
is right at the top of that
Right there.
vessel,
Right there.
right where the IVUS is.
Yep.
Probably that's exactly where
Yep,
this lesion
that's
is.
where we was.
That's where it looks like it's coming into the medial area, medial layer. But mostly it looks adventitial with extrinsic calcification.
So this is important, guys, because I think that we have to now become savvy with our choice of devices. We have so many devices in our lab. We're very lucky here at Sinai. We have pretty much everything. But the point is that our issue here is that we need to make a decision based on what you have. And so angiographically, you have a good predictor. IVUS increases your sensitivity and your specificity to be able to tell you what you need to do. And then for sure, Vishal, you got a great point about the clinical outcome. Do you treat the entire thing? Do you treat the focal thing? I think that's another discussion. How are we going to decide where to treat? Because if you look at the IVUS, there are areas of extrinsic compression, and then there's areas of positive remodeling. So where you seem to have a lumen. But I want you to play the IVUS one more time, guys, because I want them to see the IVUS after they see the angiogram. I want to show the angiogram, just a dry, cine run of the angiogram. And you'll see the lumen looks pretty large, right? It looks not bad. You would probably say, hey,
Right,
let's leave it
exactly.
alone. Now look at the IVUS, and now you'll see why the patient is so symptomatic from distal to proximal. You see that the positive remodeling has helped, but however, there's areas of really, really compression, which has really caused elevated velocities in the ultrasound in our lab, such as there, and there's even an area which is more, where you have more than 60, 70% luminal reduction of this vessel, although angiographically, even in multiple views, you're not really able to see that. So I think that, first things is when you have calcium, I think you need to look at an intravascular ultrasound. So now we've decided, I think as a consensus, because the two of you know we got everything in this lab, right? What do you want to do to treat this? Let's start with Karthik.
I would probably use a balloon. I mean, unless if you want to use a shockwave, you can use a shockwave. I would use a shockwave.
Set it up,
balloon
please.
this, set it up, prep the vessel, and put a Supera. That's what I would do.
DCB or no DCB?
I would not use a DCB here. I think this is. I think we're only stenting about 120. So I think Supera will give a very good patency for 120.
Sure.
I don't think patency. Just looking at price standpoint.
Yeah.
If you're using it, what do you think?
No,
Vishal?
I would probably differ on the stenting part. I would do shockwave, like you said, or aggressive PTA and then I would do DCB and see how it looks. And if there's any focal dissection, then I would probably go for focal Supera stenting. That's without fail. But primarily, I mean, the data on DCB and calcification is promising. Of course, Supera has very good data. There's no doubt about it. But there's no head-to-head
But Vishal, I
between
think
a
the
Supera and a
calcification we are
DCB.
talking about is intrinsic calcification, right? Medial calcification.
Right.
This is eccentric though. It's causing, the eccentric calcium is causing a luminal reduction here. So how would DCB help us here? I mean, we are using, we're using a Shockwave.
If you're using the Shockwave, then technically the goal is to break over that calcium to get us the luminal gain. And then because there is intimal and medial destruction, DCB hopefully which should help us with the patency of this calcification.
Well, you know, Vishal, you bring up a very good point, and so does Karthik, and the arguments are reason why Disrupt PAD3 is being run.
Right.
So what they're doing actually is they're looking at severe calcification in one arm. Not that this patient is in a trial, because we're not putting him in a trial, but the point is that, they're looking at impact SFA versus with balloon angioplasty versus Shockwave plus impact to see whether the Shockwave increases the efficacy of the impact SFA balloon in calcified lesions. As you know, there's a lot of controversy about calcium and DCBs. The only one balloon that is shown to work in severe calcium, at least out to 1 year, has been the Stellarex balloon. The Stellarex enrolled, especially the U.S. cohort, had the highest number of severely calcified lesions by their definition. I mean, and I know they're working on different definitions of calcium to see whether it works on different ones. And I'm, having used a lot of them, the three of us, I think we feel pretty confident that that balloon performs well. So I think with the current data and this kind of lesion, if you are, I'm not saying you should, going to use a DCB, probably Stellarex is what you should use. So, but the second thing is, the expansion, what Karthik was talking about, is the key. So I think by using IVUS and using our angiographic clues, we've figured out that we're not going to use a directional or a rotational atherectomy. The knee jerk in this case is to use a rotational atherectomy and say, oh, okay, I'm going to go ahead and do it, or a directional atherectomy and cut out the plaque, or cut out the calcium. But the point is the calcium is not within the vessel. If you go back to the IVUS one more time, guys, I want you to look at the sparsity of actual atherosclerotic plaque within the vessel, right? You have the, if you look at the outgrowth of, there's no plaque other than calcium. So this begs to the old thinking that calcified atherosclerotic disease is actually burned out atherosclerosis at its end stage, right? I mean, I know that Sandeep has done a lot of work on this. So the question is whether or not now we've come to a point where we can use our technology to direct our therapy. So at least the three of us here are in consensus that we would not do atherectomy. I agree completely with you, Vishal, and you, Karthik, that you could do either balloon, a heavy-duty, Conquest, or a heavy-duty Dorado, blast this open and put a Supera. Or you could use a newer, more, in my opinion, a little more elegant technology like the Shockwave balloon, and go in and actually focus our ultrasound wave, or is it a lithotripsy wave, right? It's not an ultrasound. Lithotripsy wave to go ahead and break that calcium and then decide. So for lack of, keep being winded, we're going to go with a 6060 Shockwave balloon. Now some technical tips on the balloon. You'd like to size the balloon a little bit higher than 1.1 to 1. That's for sure.
Right.
Second, you want to be able to understand that the balloon is going to do 180 pulses, right? Is it 180 pulses, my dear? 180 pulses. And what you want to do is the center two dots of the balloon are going to be where there's the heaviest focus of this. So when you have a really resistant lesion, you want to take the center of that balloon to that lesion, and you want to allow it to sit there and be a little patient. Don't be Prakash, be a little patient. So it's very important to sit there, because we did a live case in Arch, and we used a Shockwave balloon, and I really believe we probably didn't do it justice. So I think part of that is you have to go ahead and learn from the mistakes that you make, and maybe the understanding the new therapies. But this is a phenomenal technology that we're going to go ahead and do it. Hello, we're almost done, my dear.
Let me ask you a very basic question.
Yep.
When you see such degree of calcification on a diagnostic, purely from a technical perspective, do you go with a 6 French or a 7 French? The reason I ask is, I was doing a case last week on a 6 French with severe calcification, and I cracked up. I used all kinds of balloon, and eventually I ended up perfing, but I was in a 6 French system. So I had to exchange to a 7 French to put a covered stent eventually down the lane. So my only question is, instead of going through that process later down the lane, would you preemptively go up on a higher grade, like a 7 French system to begin with?
What do you think?
Vishal, you know, PK always tells me not to do so much calcified lesions in the outpatient lab.
Yes, always.
But
I do.
I still do some. But
So you
whenever
don't
I
use
do calcified lesions, by
7.
default, even in outpatient lab, I use 7.
Yep, I agree.
Yeah, it's just
By
basic
default, I
technical
use
questions.
7. It's just not worth it. I mean, one French, I don't think is going to make a big difference, and especially if you're planning to close the patient, like per close device, 6, 7. I really doesn't think it makes a big difference, as you know. I usually just by default.
Yeah, I
use,
guess it's a great learning thing, especially from just basic technical aspects.
You know, Vishal, I think you bring up a good point. As the technology is getting better, right? I think you know that we have 6mm coverage stents in the 018 family that go through 6 French devices.
Hold on.
But generally speaking, with our SFAs, and when you need a larger stent, you're probably going to have to go with the 7. And I do agree with you that more and more we're getting away from the that's wrong, guys. Right?
Yeah, right.
Right.
Yes.
Oh, we're getting away from the larger
Bore.
devices.
Right.
But I think one of the things that we've talked about a lot, you and me,
But we need that.
we need the wire.
I will.
Oh, that has to go to her. I see. So we need the wire. Why don't we show the setup, guys? Can you film the setup? So you can see Dr. Guja is giving the sterile wire to our colleague here, who's going to pull it around the balloon. I'm gonna go ahead and keep the handle is not sterile, but everything else is. So I'm holding my balloon here, and I'm fixing my wire so my drape is not pulled. And now Dr. Guja is going to give me try to give me a rail because it's kind of uncomfortable. And I think usually we should get the balloon down there before we wrap it. I think that would be the tip that we would tell everybody. Before we attach the balloon, we should get the balloon down there because it's going to be very tricky now to try to get the balloon down there. But we'll try our best. So what I'm going to do is Dr. Guja is going to try to hold a rail. So I think to answer your question, Vishal, I think it's very important for us to try to because remember the filter, the wire is not far. So when you're in this kind of situation, your filter's already back. Yeah, is to watch your filter.
Hold on.
What happened?
The filter is coming back.
It's a faulty balloon.
It might be a stiffer balloon. That's why you probably have.
What happened? Oh, you're getting air, so you want to walk it out? Okay. So I think we're gonna walk it out here. We'll do it again. Okay. So Vishal, as we were talking, I think that in this case, you need to be prepared to do to do multiple different technologies.
So just one point, PK.
Oh, about the calcium, one thing I want to say. So I think yes, Vishal, I think you should go with the 7 French.
Okay.
Ready?
So,
okay.
Which I just want to reiterate a point. I know PK tells in every case we use IVUS that IVUS is so important. I mean, I never realized the importance of IVUS. In the outpatient lab, I'm doing IVUS now. Almost like 1 in 3 cases, I do IVUS. It gives, IVUS is so much, the amount of information IVUS gives, especially in patients with diffuse disease, it's just incredible. I've never realized so much, and it's totally reimbursed, completely reimbursed. That's the best part about it. And especially if you have long segment disease and everything, IVUS gives so much more information. I think they should have a very low threshold for IVUS use when you're doing long segment lesions like this or calcified lesions.
Yeah, I guess specifically in this case where like PK was talking, the luminogram is not that very impressive of a significant, disease all over. IVUS, I guess, gives a very good information of how to deal, where to deal with it, and the further modality of treatment. So I guess it's a great help in this case.
I don't want you to do that at home. We just push the filter down with our Shockwave.
I mean, we didn't balloon or we didn't do anything yet.
So we're just gonna keep the filter a little way. So I'm gonna start a little bit lower, right about here. Can you give me a little die so that everybody at home can see where we're going to start here? So I'm just going to put the Shockwave down, give you a little die just to show you where we are. So it's probably
the main chunk is still okay. Yeah,
I'm going to pull back a little bit here. I'm going to probably start from here, right? Let's start from here.
That's the.
I like that.
So that's your center.
So let's go. So first thing you want to do is inflate to 4 atmospheres.
Right.
Right. Come forward. Get
seconds.
the okay. So we're going to inflate to 4 atmospheres very slowly. And then I want to see the Shockwave go up slowly. Okay, Karthik is not quite at 4. And there he's at 4. Okay. So now we're going to start. Ready? I'm going to press the button, which is, again, as you guys see, I'm very facile with these things, technology. Right here, okay. Okay, I'm going to hold it, right? Am I holding it?
Yep.
Okay,
Yeah.
I'm holding it. And how many pulses am I waiting for?
30-second pulse.
30 seconds. 30 pulses. Now let's see if the balloon expanding. So remember, the middle two dots, between those two are where you're getting the most power. Is those air bubbles going to affect me, my dear? So it's doing okay. All right. So again, it wasn't prepped well. We have to go tell Sandeep how to prep balloons again.
I didn't prep it. It was Dr. Puja.
It's always the fellow's fault. You know that. Okay, 30 seconds. Yep. Now we're going to go to 6 slowly.
6 atmospheres.
Go to 6,
I
Karthik.
had someone else to blame this
Okay.
time.
So we're going to go to 6 atmospheres. And then I'm going to go up again, agreed? I'm going to go in the same spot.
Yeah.
One more therapy at 6 atmospheres. Now remember, come off roadmap for me. I mean, the other one.
So
whatever.
technically, with every balloon, you can do 6 cycles,
yeah.
correct?
What's that, brother?
With every balloon, you can do 6 cycles. 30
Yes,
seconds,
yes.
6 cycles, 180 seconds.
We're going to go to 60 here. Hold on, still not expanding in that spot. So I may come down and bring my middle 2 over there and go for another 30 seconds. That's 60. So down with the balloon. I think, yeah, I'm going to go back again. I'm going to come down. Actually, I'm going to come down one more time here. Hold on. Right there, Karthik. Why don't we do it there? Yeah, we're going to get some of the air out here. That's okay. So I think this is the technology, and I want you, Ray, can you go minus for me and show me that balloon? I want to show people. So you see how it looks like to me, even balloon angioplasty-wise, everything is within exterior to the vessel. I don't see any plaque in the vessel. I don't see any exophytic growth in the vessel. I don't see the balloon being compressed within the balloon. I think it's all outside pushing in. I mean, do you agree, Sandeep? What do you think? Or it's impossible to tell?
It's impossible to tell. Plus, what happens is.
But why is it impossible to tell?
Because if you take a cross section on pathology,
Right.
The whole process is in this new intima, or when there was a plaque, let's say 20 years ago, it was
Right.
all non-calcified.
Right.
By definition, we define vessel wall by the adventitia.
Right.
If on IVUS, I still believe, I may be wrong, but I still believe that all this is kind of within adventitial limits.
Right.
And on the calcified side, it's difficult to tell where the
Go up.
adventitia is because of the shadowing.
All right. Fair enough. But would you do atherectomy here, or would you do what we're doing here?
I would do what we are
Four?
doing for,
Four?
for one reason,
Going up
to get a
again.
lumen. And then I want to avoid dissection, that is 2. And then, that eggshell cracking is what really is the beneficial aspect of this.
Well, we are going to go up with a balloon again. Okay, pressing now. Again, I fall asleep when I talk. It's part of my what is that called again? Sleep apnea. It's called sleep apnea. That's what happens. So here we go. So we're going to go up to 6 now, Chief. Stays at 4.
Yeah, it's staying.
Now you can see how it's expanding a little bit more. Everybody agrees
Right,
a little bit.
especially the distally part. Even
Right.
the middle part is
Middle
actually
part
better
is
than what it
expanding.
was before.
Now I'm going to pull back again and do it one more time.
30.
What do you?
Yep, I'm waiting for 30. That's
Okay.
it. Now we're at 30. Go to 6 atmospheres here, Karthik.
I did.
Yep. Okay, down. Yep. Now we're going to pull back again. I'm going to refocus the
Right
balloon
there.
right
Right there.
about
Right
there.
there.
Let's
Yeah.
do it right about there. Okay. Go to 4 atmospheres. Get our IVUS ready for another run here. Ready? That's 4 atmospheres and going up again. So now we're going up again, and you can see it's definitely making a little impact here, as much as we can. Go to 6, Karthik. There you go.
That's the area to hit.
Yeah, I can see. Do you
Yeah,
see up
it's
top
expanded.
now, guys?
Yeah.
Yes.
Does
much
everybody
better.
see what's happening?
Yeah. Between 1, 2, 3.
So
between
let's
3rd
see
and
this
4th
again.
balloon.
Good. And you can see that the distal plaque is what I don't like.
Yeah.
So let's come back down and hit it again. Let's learn from what I did wrong in arch. Wait, we're not done yet. 120, we're done. Down. So now I'm going to bring it down one more time and hit it again.
Right
That's
there.
is that my middle 2 right there?
Yes.
Pull
Pull
back
back a little.
Pull back a little?
Back, yeah, back.
Back a little.
Right there.
Right there.
Okay.
Yeah, right
Ready?
there.
It's another course I failed in grammar school math. Ready? Ready?
There are the
Go
middle ones.
again. Go again. Right, 2. Yeah.
What's the median?
Medium, mean, and what is the other
Mode.
one? Mode, yeah. Go to 6. So since you have 180 pulses, you use all of them, I would not pull this balloon out till I exhausted every aspect of this balloon and really get my biggest. Look at that, it's starting to expand again. See that? Dr. Guja's at 6, and we're going to keep on going up here. I mean, it does. I'm going to go one more time in the same spot. How come I'm done? It's not going up? 10-second pause. You learn again. Now when it double beeps, you go up again. And I'm just going to give it all of it in the spot. You can see the proximal end is expanding even more. I definitely think it looks a lot better. Let's take another picture here, guys. Okay. So definitely now we're getting a little bit more expansion. You know, I tend to always disagree with Sandeep, and I can continue that because I think, nope, go up again. We're not done yet. Yep, I think that this clearly is not a lot. I think the majority is compressive. I cannot imagine that this is inside the vessel wall. I think I'm going to scrub it with Dr. McKinsey in one of his cases and then decide where it is. Okay, we're done now. Down? No, I think we're done. So now we're going to do another IVUS. Can you show me down below, Sandeep, so I can see the wire?
Yeah, sure.
Okay, fantastic. Okay. Thank you. So again, watch your filter as you come down. Sorry. So now we're going to do just a regular picture just to make sure we haven't gotten any perforations, which Shockwave really never does. And I think that actually it's pretty impossible to do. But I think what we're going to do is we're going to do an IVUS to really tell us what's happening. So I'm just going to do a regular cine run. No DSA here, right? But thank you. Ready, guys?
1 second.
Okay. Inject. I don't know why everybody likes to mag up so much. Okay. All right. So the lumen hasn't changed much. Everybody would agree. So now let's go with the IVUS. So remember, I don't think a Shockwave is going to prevent recoil in these severely calcified vessels. Although in the Disrupt PAD1 study, there was a very little flow limiting dissections and need for stenting. So but those were a little bit smaller lesions in terms of length. But clearly they did complex lesions. I saw them presented in Link 2 years ago, and then also in Circe. They did really complex stuff. So there's no question. But their stent rates were very, very low. But I think that here, I'm not saying we're going to stent. I'm going to say that we're going to hold our breath till we balloon and see what the result we find is. So here's the IVUS. I'm going to go down distally again. Okay, here's distal. Okay, let me go. There we go. Let's start here. Ready? Ready, guys? Record. So pulling slowly. Now remember, this is areas that we did not treat. There's eccentric calcium there, but a reasonable lumen. And then here there's lumen. I'm going to now get to the point.
Starts around 5.
Yep.
Yeah.
So we're going to start. We started around
Right
here.
Yeah.
This is where we started shock waving.
Yeah, it's all, I guess we have to see the calcium and if there's any cracking of the calcium in the medial wall, because I don't think we'll get enough luminal gain. We'll probably get.
Well, I think also
once
the
we get
resolution
PTA.
of IVUS versus OCT are different things, right?
Yeah, that's
I mean, clearly we have a better
Definitely
lumen
better
here,
than
I mean,
guys.
it looks definitely better.
Definitely
Look
better.
at
than
much
this
better.
one.
Look at
Much
this.
better.
Like this is in the bulk of the lesion,
Yeah,
guys.
much better.
Right there is where Dr. Gujan, you were saying, is the exophytic, possible exophytic calcium, but still a better lumen.
Yep.
Right? So I got a better lumen. So now the proof's in the pudding. So now let's go with a I don't know if a Dorado will go. You think it'll go through this?
Yeah, go Dorado.
Okay, give me a 6.0 Dorado
6080,
or 5.0. Let's go with the 5.0. Huh?
5080.
5080 Dorado.
Do you think a scoring balloon would have any advantage in this case?
Well, I think, Vishal, that's one thing we didn't talk about prior to doing this, okay? I think once you've spent the money on Shockwave, which, it's a new technology, and currently you have to take a second mortgage on your house and different things. All kidding aside, she's already rolling her eyes. All kidding aside, I think it's a new technology. It doesn't have a reimbursement associated with it, and I know the team at Shockwave is working very hard to get that done. But I mean, so I think you're already using a technology that's not quite reimbursement other than a balloon angioplasty at this stage. So I think if we can get away with just using this technology with a regular balloon, I think it's better. If you were going to go with say a scoring balloon, I think that might have been our initial thought. Just go with the scoring, don't use the Shockwave, and then do what we need to do. So at this stage, in my opinion, we're committed. I think we did a very good job in utilizing this technology to the best of its ability. And now I think we're going to go ahead and balloon angioplasty and see the results we get. The one thing I'm worried about is whether this this balloon, the Dorado balloon, is going to track on our 014
Yeah,
wire
that will be the
with a
next.
filter there. I remain skeptical, but let's see. I've been proven wrong by Dr. Guja most of the time, so I will defer to his judgment.
Mike, because it's a bare wire, so it's a little
Right, a little bit more
stiffer
stiffer, no question. But I think that
Yeah,
they
but
just work.
Dorado is a,
wire. Yeah. So I took a 5060, a little bit shorter balloon.
Was it?
yeah. Yeah,
So
shorter
we-
balloon might work.
Question is, we are
No,
taking a
I thought
50
maybe we
balloon.
don't have a code for it,
What
so
is the
just tell
next
him to
step?
put it
Peter?
as a
What are you?
litho-
What are you?
Atherectomy,
I think we
some kind of
look at the
atherectomy.
lumen and then we decide.
no
I mean,
code for it.
one of the things that was interesting, we were doing analysis, guys, yesterday of some of our lesions in women, and what we found, boy, what's the wire? What we found was the lesions in women tend to be, we are overestimating the sizes. Reference vessel diameters are actually small, around 5. So I think we should be okay. A little bit higher. Reference vessel diameters are a little bit around. So actually,
Okay.
oh, beautiful. Are actually around 5. Well, why don't we start? You want to start at 5? Okay, right there.
Yeah.
Perfect. Let's start here. So we went with a smaller balloon. Again, it's not usual teaching because we're a little worried that we're going to, push out everything. So now we're going to go up. Let's see what atmospheres it's going to expand till. So Karthik is going to let us know how high he goes up.
Going 8, that's
8.
nominal.
Okay, I would go
Good.
here since we use a 6
Yeah, 6.
Shockwave. So go to, what's maximal here? Rate of burst?
Rate of
24.
burst is 24.
Go to 24.
Yeah, I think the real issue would be the
Because remember, Vishal,
recoil.
one comment. There's a non-compliant balloon. We're not really going to increase a high the size of the balloon. We just want to expand.
Right.
Down. Give me a 60. Give me a 60 120 Shockwave. I mean,
Dorado.
Dorado.
60120.
Do you make
60
a 120
120.
now, right? You
Dorado.
don't make a 120 Shockwave. What sizes do they come in?
They're all 60.
Uh huh.
They're 3.5 up to 7.
Ah, okay. So
That's
they're
fine.
all 60. The largest length that
opened
they
up-
come up
it
to
opened up much better.
but it's a-
is 60, and
that's
they
fine.
from 3.5 up to 6.5.
Vishal, just see how it pushed off the whole calcium. there.
Yeah, see, that's what I'm saying. My real concern is the recoil because, like we talked about,
Yeah.
the calcium is all outside. So
See,
we'll
that's why I
expand
was
it nice.
saying,
Down.
doing
And
a
then it'll come
DCB
back.
here, there might be a significant recoil. I
No,
mean,
no,
we
no.
did- we
6080
did
is
we
the,
did two, we're
if you
doing
have
two
6000,
expensive balloons.
Go up here.
No.
And if
I-
the patient
You
gets a
have
recoil
600?
and comes back
I
to us
agree.
with symptoms after a year, I would prefer to put a Supera, which is like the Supera here we're
He wants
talking about is
100.
120.
Because
So
they
the
cover two
patency for
lengths.
120 Supera is pretty good.
That's-
It's nicely
Yeah.
deployed, and we're prepping the vessel very well.
Down. Now, guys, we're going to go with a 6.
6000 I'm
Yep,
getting.
60-100 since 120 is not available at this stage. So I think those are good points. I think we have to at some point become very conscious on our utilization, and I think the putting a DCB when you may get recoil is an issue. So at this stage, Dr. Guja's point is very well taken, that we will go ahead and use a 6.0 and then do another IVUS to see where we are.
No, some might ask if you're using a Supera, if you're using a stent, why use a Shockwave? The reason why you want to use Shockwave is because you want to expand the Supera and prep the vessel nicely. That's it, because it gives a better patency for Supera. So just by putting Supera, you don't get patency. You have to prep the vessel very well.
Correct.
The Supera has to expand very well. I think this has been proven in all the trials. So I think the Superb trial clearly showed it.
Yeah, and I think this is a good point that Dr. Guja makes. The thing that you don't want to do with the Supera is get in there and do it. But I think the real elegant part of this case is our algorithm for understanding the severity of calcium. And I think myself and Dr. Singla, and as well as the two of you, we're going to write that up. I'm going to make it a project here to put an algorithm for writing up this. We've been utilizing this. Walk it back a little bit, Karthik. We've been utilizing this quite a bit, so we're going to write up an algorithm. Go up. The problem is it would be nice to have some histopathology to confirm what we're doing, within the thing. And it's going to be met with some criticism, but let's see what people say. It'll be fun. But I think that this is the future. Utilizing technology to guide your therapy is going to be the future. So you can see here again, a little bit of pain, honey. Now he's going to go up a little higher because obviously we can do this. Now, I cannot believe that this is within the lumen, boys.
Yeah, this is not.
I hate to say this.
This is expensive.
I mean, look at this.
No, it's just that one spot we keep talking about.
But
is
I'm
that
saying that I just don't believe it's within the lumen. You can see the compression on this. Go up to 20. No?
It's very tight. Go
Go to 20. Go slowly then. We got to crack it though, right? 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20. 20.
You probably might have ended up using a short 6020 or something to really crack that focal area.
All right, I agree with that. Let's go with a 6040 Dorado
40.
now.
Especially that proximal
down.
segment is still tubular and not
I totally
well
agree.
expanded.
6040 Dorado. Do we have a 7040 Dorado? Give me a 7040
Yeah, I think
Dorado.
70 is even better.
No, I would. Let's walk it out. Let's walk it out. Because I think the 70 we can hit it with. You want to go with the 6? I'd go with the 7. Let's go with the 7.
I'll go with the 7 and then a 5.5
Yeah.
Supera.
I mean, we'll go carefully, but I think we need to get on this lesion.
740.
We're done.
This is
See,
what
now
we
it
call
clearly
the-
proves that when Karthik takes it out, the filter doesn't move, but when you take it out, the filter moves. So it's a perfect
Thanks, Vishal.
randomized trial to tell us that me and Karthik never put the filter
You
out.
are so mean to me. You know.
I
that?
just was waiting for that live case to say it out loud.
Don't worry. I'm going to ask our wonderful team here from the audiovisual to delete that sentence.
Okay.
That will be deleted from the tape.
You know, Vishal, whatever you say, everything can be edited here. So.
I know, I was going to say.
And PK edits everything. So
No, I know. All of it is unedited. You guys know that. Oh, my goodness. So this is going to be the final balloon, and then we're going to make an IVUS run.
Now, PK,
And
you
then
know,
decide.
Vishal, I don't know if you can see, but PK is not able to put the wire and balloon together. So I'm very happy he's not staying home to teach the kids algebras and all these stuff.
Ready, Paul? Ready? Let's watch our filter. So again, be paranoid of the filter with these bulky balloons and poor runoff. Be paranoid of the wire, and you can see how Karthik is keeping the wire in the field. As difficult it is to watch, and slows you down a little bit. You'll be grateful down the road that nothing bad is happening to your patient. So since we're going with a higher balloon, we're going to just focus it, like Vishal said, on the spot that we're concerned with, which is right there. And then we're going to go up slowly. Dr. Guja does go up slowly because of the, it's just something that he's not as rapid. I would just go, no, this is good. I think this is the spot. You'll see. So we're going to go up here. So we're doing this to really ensure that we expand our Supera. So you know that, a lot of people are worried about ballooning at higher pressures, but this is needed here.
See how the balloon is technically trying to wrap around the vessel because
Yep.
of the eccentricity of the calcification?
What do you got?
You can actually appreciate how the
12.
calcium is moving around and so is the balloon.
14,
Wow,
16,
that is tight.
18.
Ay, ay, ay.
18, go to 18. It's okay, we'll deal. 18, maybe you can go to 18.
Sandeep, get ready with a covered stent.
Yeah.
18. Okay, 20.
You have some wire bonds. What wire bonds would we have?
I would
Keep
go.
7060
I
and
mean, you have to
7080 wire
open
bonds.
it, right? Go to 18.
There.
Wire bonds.
Let's
Maybe
go to 18. Slowly.
Yeah.
You got to give the balloon time to work. So you got to let it give, right? So you just give it slowly. If it gives the wrong direction, then you deal with it. Like I told you, I always use the sentence. You either you got to poop or get off the pot, right? So you're on the pot now. So time to take a poop. So just go slowly. Hang on, my dear. We're opening it up. So we're just going slowly, trying to get this open, and it's giving. It's giving. Just again, Dr. Guja's technique of balloon angioplasty should be admired because look how slowly he's doing it. See, just
now
let
it's
it,
opening up
just let it expand. I don't think there's any reason to go above 18 here because I don't think you're going to get any incremental benefit. I think we just go say 18. Rated burst is 24, so I'm just going to just let it just expand. I think once we get to 18, we're going to leave it up. Okay. So that is at 18. Okay, let's leave it up now for a few minutes. Now, why did I choose 18? I have no idea. But I think that's going to be the area where at least you're going to get a nice lumen. At 18 atmospheres, what's the size of the balloon, guys? Can you look at the
7.6.
7 point? No, it's probably a 6 point something.
Oh, this is 7 balloon.
Yeah,
12, 8 is nominal, right?
18
It goes 7.
atmospheres.
It's probably not going to be much anyways. Probably 7.2 or 7.3.
So again, okay, now we've definitely prepared the vessel. We've achieved our goal of preparing the vessel, right? Okay, so down. So now we're going to watch the balloon come down, which is going to also tell us how this do. And now I'm going to ask Dr. Guja to just inject, because this is where we may have a perforation that you want to recognize with the balloon there, right? So Dr. Guja is injecting, and I think we're all very good that there's no perforation. Everybody agrees?
Yeah.
So let's take a picture for teaching purposes. We'll just take, just tell everybody. that there's no perforation. Okay, I think everybody
5.5
agrees.
is fine, yeah.
So let's go with a 6.0 Supera, right? Oh, 5. I'm sorry, 5.5 Supera.
5.5.
I agree with Karthik. 5.5 Supera is the way to go.
So are you happy with the proximal edge, I mean the proximal segment expansion?
Do you want to balloon it one more
Karthik?
time?
Yeah, I mean,
Okay, let's go up here.
I think I'm okay with that, Vishal. For 5.5, I think it's okay, and a vessel looks like it's around 6.0.
We'll go up slowly.
Right. So I think 5.5, I'm okay with that. If you're putting a 6.0,
See, it's expanded,
standard.
Vishal. See that?
yeah, now see, exactly.
Yeah.
I mean, I guess I'm
Get
just
down.
being an extra whatever.
No, I'm glad you pointed it out because again, I think that's a great point, Vishal. Because if you go in with the Supera,
Right, exactly.
and now you're pooped, you know.
It's a very good point, Vishal. People have to understand that Supera is a very good stent as long as it's expanded very well.
Right.
And that's the only way you get a good patency with Supera.
Yeah, it's like underestimating the Supera. I mean, it's great, but if you don't prep the lesion up, you can go the
Yeah.
other way and just
You
have
can make the
poor
120,
patency.
160, and then now your patency is back to like
Right.
any of the bare
Ibis
metal
guys.
stent.
Yeah.
But now let's go back in with the
Specifically,
Ibis.
when you can't control its tangential. I mean,
So everybody can see how
Radial
well the Ibis performs here, and and I think now Vishal, we've done everything we possibly can to open this vessel. Gone with a 7.0 Dorado after doing a 6.0 Shockwave. The only thing I could think about is should we have gone with a 6.5 Shockwave to begin with.
so
And I think that's the only thing I can think about. And I think that's part of the learning curve when we get that algorithm together and decide is bigger better with Shockwave because we're going to be able to transmit the waves, and the pressure as we all get through even a little bit better. But
I
anyway,
agree.
we'll find out sooner or later.
we
Here we're coming from 5. The record.
we just spend all my month's salary right here.
That's actually true. I mean, the joke is that as reimbursement goes down, technology is needed to do this, and I think it's very important that CMS and all the other. It's very good lumen.
I hope IRS is not watching this.
It's actually a very good lumen.
Trust me.
Look at that lumen.
I'm
It's
the
a
last
very,
person.
very good lumen. I think, and look where we are in our IVUS. It's an excellent, excellent lumen. So I think now I'm very, very happy. Now I'm gonna check my filter, capture my filter, and then let our Supera expert, Dr. Guja, go ahead and deploy it. And then we'll go ahead and take a picture. Actually, or maybe I should do this one,
5.5,
Vishal. What do you think?
Yeah, I think you
you
should
feel
do it.
adventurous?
No.
No, Vishal doesn't feel adventurous. DSA?
5.5 120 should be good.
5.5 120. That's fine. We got to capture the filter though.
Yeah.
And then give us a. Go ahead. Just check. This is the normal procedure we do here. Check the filter. Make sure our filter is not full, which we don't. Look, Shockwave does not embolize. I'm not worried about embolization with Shockwave.
Beautiful.
What I'm no with the Supera it'll move too much. I think what we're going to do here is capture the filter, put down a Sparta-core wire, and then we'll go ahead and do a Supera over the Sparta-core wire. You can use an 018 wire, but again, I want everybody at home not to think that Shockwave embolizes because it doesn't. We did that as part of the algorithm because we weren't sure what we were going to do till we had the IVUS ready. The filter was used in case I was going to do atherectomy for exophytic calcium. So I think that's important. Show me down below, guys. Grazie.
In this present day technology and use of Supera, would you ever think use of covered stent in this severely calcified lesion would have any role besides perforation or complication?
Well, I'm just worried about runoff, right? I mean, you're talking about that usual shave and
Right.
I mean, pave and cover kind of technology thing.
Correct.
So
Yeah.
Vishal, even covered stent doesn't give you that radial strength, right?
Right.
So if you have so much amount of extrinsic calcification, unless you're worried about perfing a vessel, I don't think even putting a covered stent. Yeah, I mean, you can say you can put a 6.0 covered stent and just keep blowing it up, but I don't see. You think it's beneficial?
Well, I think if you do a coverage stent in such a heavily calcified lesion, you might have to do a what is it called, a Supera within.
Yeah.
So I think that may make sense, Vishal, where we do a Supera, like you said, after the coverage stent, and expand it enough to say,
No,
Show me,
Vishal,
huh?
we're talking about 2 months of your salary.
and then expand it to say that we will do it, I think that may be the way to go here. Okay, that's good right there. Excellent. So now we're going to go ahead and let Karthik work his magic. Come up from there, right there, from 5. And I'm going to step aside, let Karthik show you guys how to do this while Vishal and I talk. So Vishal, I think this is a very, very good, and when Karthik is ready, we'll go back to his technique of deploying it. But I think, Vishal, I think this is a very good example of how do you choose technology? You have so many technologies that you're available, and we're all tend to be creatures of habit and do knee-jerk reflexes of just saying, hey, you know what, I've got calcium, I'm going to do a CSI, or I'm going to do a jet stream atherectomy. Well, the reality is I think we need to become a little bit more elegant than that. I think we need to analyze the calcium with the technologies that are available, and with the technologies that are available, we will be able to say which will be the most effective in the type of lesion that we're treating. So this is a classic example of using that technology, which is intravascular ultrasound, correlating with your angiographic findings, choosing the best therapy. So now the best therapy in our hands at this stage is a Supera stent followed by a PTA, which is what we're done. So right now, Dr. Guja has measured it up, and I want you to go ahead and watch how he deploys the Supera.
You want to go more higher?
Can you focus on his hands, guys?
You want to go more higher?
You want to pull back a little bit,
Flora?
Yeah. I
want to
don't
go
think
higher,
he
man?
needs that much.
You want to go higher, Mike? Sure, but you like that position right there?
Yeah,
I like
this
it
one
too.
because it's going to definitely, we are
Expand.
cutting right on the corner, but it's going to elongate a little bit.
A little
for
bit.
Sure.
I agree. So I'm just going to let Karthik show. I'm going to zoom. I'm going to shutter in for him. There you go. So it reduces radiation, and then we're going to go for it. So Karthik,
You don't have to go this high on the mag, right, Vishal? But I think we are demonstrating it. So normally two pins, one proximal and a distal pin holders. So basically we unlock the distal pin, and then we go half length of deployments, and then you pull back. You go half length and slowly deploy. The shorter you deploy, the better deployment you get, and you have more control over the stent. So you are pushing and pulling with your left hand, but you're just pushing with your right hand. So your right hand is just for deployment. Don't push or pull or elongate the stent with your right hand. Only the left hand is used for pulling and pushing or changing the stent configuration, as PK said. So thanks, PK. So basically, slowly you just go short lengths. And
I
then
think
if
you
want to.
Yeah.
Yes.
No, go ahead.
Yes, Vishal, tell me.
No, I was just saying if you want to talk about those beads on the side and how to see.
So
it's
normally
appropriate.
you want to have a straight. If you take a lead pencil and draw it with a straight line on a paper, that's exactly how it should look, right? That's the proper deployment.
you
of
should have
Supera.
two lines on either side of the stent.
Correct.
So, but when you have a lot of calcification, it's difficult because of the calcification. Like you can see, we are elongating it a little bit. So I'm pushing it. So, and you can deploy it a little bit short and push at the same time.
So the other thing, guys, is in this kind of situation, you should have positive pressure with your left hand.
Right.
That's exactly
So
what
and
I'm
then
doing.
it's actually once you
I'll
you
just do it
stack
here.
it, you can actually manipulate the stent by pulling on it with your left hand to get it to the right configuration.
So
But what you can't do is once it elongates, try to stack it. So one of the things you need to do is just make sure you have a lot of pressure in your left hand and deploy it. And remember, we prep this vessel beautifully. It'll deploy nicely. You just have to be a little bit careful and slow. And now it's getting a little bit better. And and that's part of the reason why oversizing the balloon is not a bad idea in these kind of lasers. Hit it with a 7, crank the what out of it, and then do it. The other thing you can do also is if you do elongate, you go ahead and use a DCB inside it. I know that.
See, Vishal, here, this is the good line. You see that two dark lead lines? Here we got a good kind of stacking there. Right. This is exactly how you want to stack. Below, I think it was a little bit elongated. What do you think?
No, I agree, but I think that part of that is exactly, have more pressure on your hand and then pull back to get the configuration that you want. You can't have too much pressure because then it'll kind of indulge into itself. Yeah. So, you got to be a little careful. But I think Anish Thomas and his colleagues out in I believe, St. Louis now, have been doing Supera along with DCB in elongated Superas, and they're looking at their results, whether that it seems to kind of even the playing field. But I truly believe that, this is really a technique. If you prep this vessel well, which I really believe we did, we're going to be able to deploy this and nail it. If we elongate a little bit, you saw that there was a lot of, calcium there, and there was a little bit of recoil. And listen, that's part of the trouble with what you have with the technology available,
Yeah, no, I agree. I mean, You're absolutely
yeah.
right. The amount of tension in the left hand when you have to push forward, you underestimate it, but you really have to keep that forward tension on to
Yeah,
get it
so
right.
if you really sometimes put a lot of tension,
Yeah, it
as
can
PK
involve
said,
it.
you can invaginate the stent.
Yeah.
So you don't want that invagination because then it will unfold on itself. So one thing about Supera is once the Supera is you can have expanded and unexpanded zones. As long as you get the length you want, over time Supera will adjust itself like a spring. So as long as you maintain the length, you can go. I think if it's a 120 stent, you can go anywhere from 110 to 130.
Right.
If you go anywhere more than 20 below and up, I think your patency rate go down.
Oh,
down
tremendously.
Tremendously. So
You'd rather foreshorten rather than elongate.
Correct.
So I think here is really a testament to how well the vessel is prepped. You can see Karthik is having no problem deploying it in this area. And this was the area that was really, really tight. And you saw how we used the balloon angioplasty to do it. And then you will see as he comes back up, we'll do it. The other thing everybody needs to remember is that foreshortening is better than elongating, okay? So foreshortening is definitely better than elongating. So this way, Karthik, I'm just going to do it where Karthik, I think, is a little expanding here, maybe a little positive. So foreshortening is always better than elongating. And I think
stacking it here.
I think that's important. And he's stacking it here because it elongated at that one segment. And again, I think he should be careful because it's probably going to elongate here as well, because I think that's one of the ideas. But again, when we do an IVUS, we'll balloon this with a 6.0 or a 7.0 Dorado. Give me another 7.0 Dorado, guys.
7.0,
and then 7.0
80.
7.0 100.
700
We'll do a
Dorado.
7.0 100 Dorado through this stent just to do it. We did that. I think that'll help us a lot to be able to get this well expanded, to be able to get it down. We'll see. So here's Dr. Guja finishing it up here. We're very, very close, and he'll just stack a little more, and then we'll be able to get this done. You can see the ending is coming there, I hope, and somewhere right about there. Perfect. Perfect stenting. Huh? 150 is too long. If you have another 100, give me 100. So then we're going to walk this out without losing wire.
So no DCB technology.
Nah. Actually, Ray's bringing up a good point. Ray's asking, why not DCB?
So Vishal, if you look at the tape, right? So we started from almost 6 and we went to 20, 20, 25, 24. So it's exactly 120. It's a 5.5 120 stent.
So walk this out.
So as long as you get the length, I think over time it will just adjust itself.
Perfect.
As PK said, the vessel was properly deployed. I think definitely there is definitely I think the Shockwave balloon helped. There's no doubt about it.
7.0, 100.
7.0
Dorado.
100. You have an 80 is fine.
80 is
Liz.
fine, even 80 is okay. But not 120 or above.
So we're gonna go ahead now and use the 7.0 balloon. Even a 40, whatever you have, Liz. 7. Give me whatever you got.
60, 40, whatever we have.
So we're gonna now put a balloon in. Now remember, guys, I want you to be very cognizant that when this balloon goes down, you may have to change wires because of the 035 nature of the balloon, and now the Supera is deployed. I always
740.
tend to go with a post-still now because I think that, especially in complex lesions, it helps you with the deployment. Ray, you want to go to room 4, buddy, and room 1? And I'm going to say goodbye to Ray here. He had a very good thought in terms of the DCB, which we'll address in a second.
Yay, Ray.
Okay. So Vishal, let's talk a little bit about DCB. What is your thoughts on using a DCB? And I know this is completely conjecture here and opinion in terms of what your thoughts are on using it in a mal-deployed Supera.
I don't know. I mean, I guess it's more of a personal experience. For me personally, I don't think DCB would make any more difference on a mal-deployed Supera. I mean, I don't know if there's any real data to support it. It's just, I would probably do is just a plain old balloon angioplasty to see if I can make it more vascular mimetic the stent, which is already is, and to give it a little bit more sizing proportion. For DCB, I don't know if it adds any advantage whatsoever to a mal-deployed Supera, because what we're trying to do is get the Supera size to the vessel wall. I mean, it's not about the drug going in, it's more about the patency of the Supera per se. So I don't know what extra benefit we would get, if any, but again, I guess it's more personal. I've never done it, but I guess I'll leave it for Karthik and you to decide on that.
I don't do it too. I don't think there's a benefit. I agree with you, Vishal, completely.
So we went up to 8 here. We're trying to not come outside the outside of the Supera, so this way we don't cause any trauma. Almost done, hon. And then there's another 8. We're just trying to get this balloon nicely in the Supera, well opposed, down. So we're going to come back up
Vishal,
now.
a question. Do you feel posting the Supera, post dilatation of Supera will help.
That's another question I have. I think no. I mean Supera, like I said, it's a single wire
Down.
vascular mimetic vessel. So the way it's deployed is deployed. I think the only time it might help is if you have real elongation and you want to change the malformation. What I would do is deploy the Supera and push in a little bit to give
Down.
try to fold in and see if I can
Down.
get a little bit of more compaction on the stent strut. But other than that, I don't think
Some
it
nitrate.
really benefits.
The reason I asked you is I know PK's
50.
answer. PK always says post dilatation doesn't help. I strongly believe that post dilatation does help. I feel like, especially if it's calcified like this, I think post dilatation does help. That's my opinion.
Ibis?
50 of
But I
nitrate.
think PK is right.
Ibis? No, I think you post dilate for other reasons. One, to make yourself feel better.
Right. That's the biggest reason.
That's the most important reason to post dilate Supera. And two is to again, like Vishal said, if you want to try to push it in, I know Andre has done it in Europe where he pushed it in with a balloon. It's a good idea. You could try it, but I think you're making yourself feel better. So I think that the issue with Supera is that you want to be able to get it right the first time, right? So prepare the vessel early, do the technologies that are available, and then post dilate here. For more, the reason I post dilate, show me above, is to make sure that the struts, and that it's just a very smooth apposition against the vessel wall. I know we're not going to affect anything else.
Live?
Go live
Go
on the
live.
Ibis.
So now we're going to go live with the Ibis. Ready? And now I'm just going to pull back in. There you go.
Nice.
So I'm just pulling the Supera back, the Ibis back through the Supera. Now you see how nicely circular the lumen is, how the calcium is not intruding into the Supera anywhere. It's just real, look at
Nice.
that. Look how beautiful that is. Especially in the toughest parts of the lesion. Look how beautiful that is. Look at that. That's just
That was the
gorgeous.
tight portion.
That's just gorgeous.
That's really nice.
Right? So we're done with the Ibis. Now we're going to give a little nipride.
50.
Take the wire back here. This is 50, the whole thing?
Yeah, whole thing's 50.
Flush down, please. I think you need more. Yeah, it's not there yet. There we go. So let's do a non-DSA first. Actually, this mag is good. Let's do a non-DSA. Ready? Wait, when I tell you to inject, now. So now you can see how the calcium is around the stent, right?
Nice.
A little bit of stent mismatch distal, but that's okay, DSA. Sending.
That's beautiful.
Beautiful.
Beautiful result. Now let's go down. Now low mag, guys. Right. A little bit lower. That's good right there. Always look at the side of your filter for spasm. We haven't had any dissection or closure of vessels.
Nice.
So remember the AT was out to begin with. We'll fix
Beautiful.
that later on if we need to, if she progresses in any way. And then finally our foot shot here. Right, that's a good shot. Okay. Inject. So final picture.
Yep.
You saw the pre and the post, so especially with the flow to the foot. So, she moved a little there. So there comes our perineal, and there's our perineal.
Yeah,
There's our DP,
in the
AT
back.
coming back. So there it is right there, beautiful.
Much
So
better.
we're done.
Beautiful.
So Vishal and PK, I want to ask a question. I think
035
it's important because you brought up a covered stent, right, Vishal? So both of you guys, if you put a covered stent here, would you open up the AT to give more outflow?
I mean, in this case, probably not. I mean, it's good,
What
but
would-
dominant, prominent peroneal going right there. It's not like a small peroneal. It's a good dominant peroneal going down. So if really I have to do it, I would probably just put a covered stent, follow the patient clinically, bring them back for an ultrasound to see how it is, probably in a week and a month, and then more so clinical follow-up than a good runoff. I mean, the runoff is decent.
I think the real answer is, Vishal, we don't know. So, but I really think that in this case, I probably would, just because of our runoff being so essential to covered stent. It's a short focal AT lesion, and I think it's easily crossed, and I think that would really be an easy way for us to at least make ourselves feel better again in terms of whether we're doing enough. But I think, this is a case, Vishal, I think the most important highlight of this case is not really the Shockwave or the Supera, although
Give
they
me a
were
short
phenomenal important things to highlight the case. Short 7.5, please.
We have it.
So I think what's important is really the utilization of the angiogram and the intravascular ultrasound technology and or OCT when it becomes more prime time for peripheral to really utilize this to be able to choose the appropriate therapy for us to go ahead and best serve our patient. So again, I think we all covered all this in the case. I really thank all of you. I thank Dr. Guja. I thank you, Vishal. Obviously, Dr. Singla, and our entire team here, including our wonderful audiovisual people. So thanks again, and I will see you guys next month. And more importantly, please register for Link Mount Sinai, our endovascular course, as well as CCV, our wonderful coronary course, which has been in now its 21st year, which is incredible for Dr. Sharma and Dr. Sharma, really the founder of the entire course, and all the wonderful cases that they do. Obviously, there'll be valves as well, and all the other new technology that they're going to show. So please join us here in New York. And for the fellows, we'll see you for the endovascular fellows course, and we'll see you next month for our CCV, our peripheral intervention live case. Thank you again, Vishal, and thanks, Karthik.
Thank you.
All right, thank you, PK and the team, for a great case. Thank you, everyone, for joining us. Like I said, we can watch this case in the archive section by the end of the day on ccclivecases.org. Any questions, concerns, or comments, please do email us at info@ccclivecases.org. For the next month, we'll see you May 16th because of some scheduling conflicts. We will do it one Wednesday before. And like PK said, please do join us for our endovascular Link Mount Sinai in New York City on June 12th and 13th, and preceded by the Fellows course, specifically for the Fellows on June 11th. Have a great week and a month ahead. We'll see you next month. Thank you.